We are going to talk today about something that almost never comes up in the prior authorization debate, even though it may be the most important part of it. Everyone knows the payer's name on the denial letter. Very few people outside of utilization management and payment integrity circles know the names of the companies that actually wrote the rules behind that denial. Today, we are going to change that. So here is the core setup. When a health plan denies a prior auth request or kicks back a claim, the plan takes the political hit. The plan gets called to congressional hearings. The plan's logo is on the EOB. But in most cases, the plan licensed the criteria from a vendor, plugged that vendor's engine into its workflow, and is treating the output as authoritative. The vendor wrote the rule. The vendor doesn't appear anywhere in the public conversation. Let's talk about who those vendors are. In prior authorization, there are basically two products under most of the decisioning in this country. InterQual, now owned by Optum after the Change Healthcare acquisition, and MCG Health, owned by Hearst. KLS data puts InterQual at around 60% market share in criteria, with MCG covering most of the rest. So if you are a commercial plan, a Blues plan, a Medicare Advantage plan, or a Medicaid managed care organization, there's a very high probability your prior auth criteria were written by one of those two companies. What makes this more than just a vendor concentration story is the proprietary nature of the criteria. These products encode clinical decision trees, inpatient versus observation, imaging appropriateness, step therapy for specialty drugs, and those trees are sold by subscription. Providers appealing a denial have historically had to argue against a rule they cannot fully read. The vendors publish change logs and cite peer-reviewed literature, but the actual judgment calls about what counts as sufficient evidence are made internally, not in any public forum. Every plan running the same product starts denying the same procedures, the same way at roughly the same time. That is a monoculture with a license fee, not a market in clinical judgment. Now the claim editing layer, which gets almost no coverage but is where enormous amounts of money move. After a claim is submitted, it runs through an edit engine. That engine applies tens of thousands of rules, bundling edits, modifier checks, frequency limits, the vendor's own proprietary logic on top of CMS and AMA guidance. Most auto denials from this layer never reach a human reviewer on the payer side until a provider appeals. The key vendors here are Optum's claims editing system, Lyric, which is the old Claims X10 that Optum had to spin out under DOJ pressure from the Change deal, HealthEdge, and Zelis. And a significant portion of these vendors are paid on contingency, 15 to 30% of identified savings. That structure is effectively a bounty on denials. More denials equals more revenue. That is not the same incentive as accuracy. The third piece, and this is where it gets structurally interesting, is the ownership overlap. Optum owns InterQual. Optum owns the claims editing system. UnitedHealth Group owns Optum and also owns UnitedHealthcare, one of the largest health plans in the country. That is the same corporate family writing the necessity criteria, running the claims edit engine, and issuing the denial. A 2022 OIG study found that 13% of sampled Medicare Advantage prior auth denials and 18% of payment denials actually met Medicare coverage rules on review. A 2024 Senate investigation found that UHC's denial rates for post-acute care more than doubled between 2019 and 2022 as automation rolled out. And AI is accelerating all of this. Vendors are now running large language model overlays on clinical documentation to generate denials at sub-second latency, at a scale that makes human review a rounding error. The policy response, including the CMS rule from January 2024, addresses API requirements and turnaround clocks. It does not touch the criteria layer. It does not touch contingency pricing. Reform aimed only at payers is aimed at the visible surface of a problem whose structural roots are in the vendor infrastructure one layer up. For the full paid analysis, including the complete breakdown of every vendor, the specific policy gaps, and the reform arguments that actually address the root layer, subscribe to On Healthcare. The link is below.